Good afternoon, everybody. My name is Christian Vincent. I'm actually clinical director at FEOPS, and that's really my pleasure to welcome you into the education sessions organized by FEOPS. We are a startup company based in Ghent, in Belgium. FEOPS is engaged this year a lot in education, and that's why you will see a lot of session during the PCR London Valve focus on Meet the Experts in Digital Heart. This session today, this afternoon, is based on the learning of the predictive value of virtual implants in the left atrial appendage closure using the Amulet device from the Abbott company. Our speaker faculty today will be Dr. Adel Aminian, is an implanter based in the CHU Charleroi in Belgium. We will have a Zoom session now for almost 30 minutes, including as much as possible interactivity with the audience. The way to get interactive to the speaker, first of all, you will see sometimes quick polls, so you can answer the questions, and we will, mainly Dr. Aminian will comment on those questions. And the second most important thing for interactivity is that you can use the chat box, which is under your screen, bottom of your screen, and ask any question you want. Please ask a lot of questions. I will summarize them and asking them to Dr. Adel Aminian in due time. In the meantime, I wish you a very nice session. And Dr. Aminian, thank you for being with us. I leave you the word to you now. Thank you.
Thank you. Thank you very much, Christian. I will just start to share my screen. So here we are. Okay, we can start. Okay, so these are my disclosures. Okay, so I think the first important aspect is to define for people who are not experienced with this device, what is the Amulet device. So basically this is a double component left atrial appendage closure device. It includes a distal lobe, which has a very important role of anchoring the device into the left atrial appendage, and actually should be placed in what we call the neck of the appendage. And this lobe is linked to this proximal disc, which has the goal to fully cover the anatomical ostium of the appendage. And it is important to remind that the Amulet is provided in multiple sizes that we need to define based on your imaging before or during the procedure. And we see that the device lobe, based on the lobe here, goes from 16 up to 34 millimeter for the lobe. And for each lobe, you must add a few centimeters to have the disc diameter. From 16 up to 22, you have to add 6 millimeter to have the diameter of the disc. And from 25 to 34, you need to ask a 7 millimeter. So these are the measurements. And this is the actual sizing chart based on the maximum diameter provided by your imaging modality during the case. There are two very important anatomical landmarks for the placement of this device in the left atrial appendage. The first one is the anatomical ostium, which is an area that goes from the left upper pulmonary vein up to the inferior margin of the appendage, just proximal to the left circumflex artery. And if we go just 10 to 15 millimeter below the plane of the ostium, we get the landing zone, which is usually located at the junction between the neck and the distal lobe of the appendage. And this landing zone, the measurement of this landing zone will define the size of the lobe that you will choose for the procedure. I would like to emphasize that if you use a 2D TEE, first you need to get multiple views to be sure that you get the maximum diameter of the appendage. But even if you do so, it is important to remind that with the TEE, you will never get the true maximum diameter of the left atrial appendage, which can only be provided by a 3D data set, which can be 3D TEE. But for me, the most accurate sizing method for any left atrial appendage closure device is CT. And you can also consider that the left atrial appendage has multiple shape and anatomies and size that makes the sizing and the planning of the procedure very, very difficult because it's very patient specific. So there are many advantages of CT. First, it's less invasive than TE. It allows to detect the presence and density of thrombus. It has very strong 3D capabilities. There's a low inter-observer variability. You have the best spatial resolution that can be acquired with this imaging modality. And on top of that, you can get very important information related to optimal transeptal puncture and optimal C-arm projection to spare some contrast during the procedure. And I would like to start directly with my first quick poll that I will read right now. So, Christian, I cannot see the quick poll. Can you?
I'm logged in from another device.
It's coming, Adel.
Okay.
Mathieu, because he's logged in on our team. Oh.
Just wait with that.
Yes.
Small technical things. I propose perhaps, Adel, that you continue a little bit and we will.
Yes, I can continue.
In a couple of slides, yes.
We can yeah.
Yes, so, that's very cool.
Yeah, so you have the quick poll now? No, I continue.
No, not yet. Which
okay. So I think that we will see that in the future, the gold standard for LA ocular sizing will be definitely MDCT analysis. And we have currently very nice softwares, as you know, to analyze MDCT images. And these are the Ozarix, Oros software, and Trimenture, which, to my knowledge, are the most commonly used software. And it is clear that you can get very accurate per procedural LA imaging with these softwares, but in fact, how to assess the optimal size and the position of the closure device remains something difficult for many operators. And this is the task of FEOPS, which has developed a very important platform which allows for a computational model for percutaneous LA closure. And you will see that based on this concept, we can get patient-specific simulation of a closure device into the left atrial appendage.
Adel, we can launch the quick poll now if you want.
Okay, you can show the quick poll.
Thank you. Sorry for that.
So the question is as follows. So how comfortable are you in LAO cases in making a sizing position decision based on standard preoperative data? Are you comfortable or not comfortable? So do you have the result of the poll? Christian?
Yeah, still people are voting. We wait for 1 second to, yeah. Okay, results are coming.
So we have 2/3 of the attendees that says that they are comfortable, and 1/3 of them are not comfortable. So I think it's very interesting. So I will go a little bit deeper into the concept. So the FEOPS concept is very easy to understand based on this slide. Actually, you provide to the platform the 3D computer model of the left atrial appendage based on your preoperative CT scan, and that will allow the system to incorporate mechanical behavior of the left atrial appendage tissue. You will add on that a 3D computer modeling of the closure device, which can be the Amulet, but they can also work with other devices. And then you will get the mechanical behavior of the device, which will be taken into account. And when you take into account these two concepts, you can predict what will be the interaction between the device and the specific anatomy. So there are many advantages, and one of the most important ones is that this platform will provide unique insight to the operator prior to the intervention, and also you can simulate different device sizes and try to choose the best one for your specific anatomy. So now I will show you some example. I just want to make open the bracket about what is important, how to avoid a leak with a per-device leak with the Amulet. If you see here, we have, let's say, a perfect implantation. The lobe is totally perpendicular to the neck of the appendage. It's completely filling the circumference of the neck. The disc is nicely opposed to the anatomical ostium. That is the perfect implantation. This is the holy grail for any procedure. You want to get a full apposition of the device, that the device is really on axis and perpendicular to the neck, and then you have a very nice occlusion that you can assess with CT. But in practice, there are many reasons to have a pre-device leak, and the two most important ones are device undersizing and the fact that you put the lobe in an off-axis position. So if we take undersizing, it's very easy to understand that the lobe of the device will not completely fill the circumference of the neck, and of course you will get a leak, as you can see here on this CT follow-up. And sometimes you can choose the right size, but what will happen that you place it in the wrong way, it's off axis, so some part of the device will not be nicely opposed to the appendage wall, and then you will also get a pre-device leak. So look at this case. This is a relatively complex anatomy, and based on pre-procedural imaging, the operator decided to put an Amulet 22 millimeter. And what you see during the CT follow-up is that you have a residual patency of the appendage. And so the question that arises now is that, could computer modeling help to predict this upfront or not? And if you see the post-procedural imaging showing that if in this case you put an Amulet 22 millimeter, you see that actually you see this is how the FEOP system works. You see the simulation of the device, and you have for each device a color plot, which is represented here, showing the distance between the device and the appendage wall. So if you have a distance of 0 millimeter, it means that the device is fully opposed. That will appear in white. And if you have, if the color plot shows you red, it means that you are at least 2 millimeters far from the left atrial appendage wall, which means that you don't have a good apposition. So you can see that, for example, in this case, an Amulet 22 millimeter implanted proximally will not give rise to a nice apposition, and that explains the residual patency that we've seen on CT. If you take a 25 millimeter implanted using the sandwich technique, you also get a relatively bad apposition. But if you place a 25 millimeter more proximal into the neck, maybe you can get in this simulation a nice apposition of the lobe. So maybe in this case, a more proximal implantation, a complete sealing could have been achieved at the level of the lobe and the disc. I just want to show you some case from my practice. This is a relatively, let's say, classical anatomy of the appendage, and this is how we evaluate the ostium and the landing zone of the appendage for placing an Amulet. This is a classical CT evaluation when you look at first the ostium of the appendage, and we use CT to do a multiplanar reconstruction, as you can see here. And for the ostium of the appendage, it's very important to cover the maximum diameter. So here we have 20 millimeter for the maximum diameter. So we should have a disc that should at least cover 20 millimeter of maximum diameter for the ostium. If we look now at the landing zone, which is located just, let's say, 10 to 15 millimeter distal to the ostium, what we get very nicely from the CT is a minimum and a maximum diameter. We have a maximum of 16 millimeter and a minimum around 13 millimeter. And if we look at this very nice sizing chart, which has been published recently by Javier Flexa, which take into account a 3D data set with maximum and minimum measurement, we look here, it's a 16 millimeter of max, and between 12 to 14, it's not good here. And then we need to place in this specific device, in this specific anatomy, sorry, 18 or a 20 millimeter device. And this is how the system FEOPS works. I will just show you right now. So first you get a very accurate measurement of the ostium and the landing zone. And then you can try to simulate different devices. So here we have an 80 millimeter Amulet device placed proximally, which fits good with some area of malapposition, as you can see here when we turn around. Then look at an Amulet 18 millimeter placed more distally. It looks good also. But you will see very interestingly that we can also move to a bigger device, for example, a 20 millimeter Amulet device, and then we get a very nice apposition of the lobe all around the landing zone. It's fully white. And even we can place it a little bit more distally. It doesn't change a lot. So both positions are totally acceptable. So this is the case. You see the angio on two different views, cranial and caudal view. This is the placement of the device. This is a one attempt based on the simulation. So you see that we are targeting between proximal and distal because both are working very well. And this is the post-operative CT showing a relatively nice concordance between what was seen on the simulation and what we achieved during the procedure. So we have a very satisfactory device depth, which is actually intermediate between the proximal and distal. And most importantly, we get a full occlusion of the appendage, which is always nice to see during the follow-up. So I can say here that the FEOPS simulation had a very important impact during the procedure. So let's hear the second case here when we see a relatively complex anatomy. It's a chicken wings anatomy, but we have a relatively correct neck when we could place the device without going for a sandwich technique. And again, I've done my classical measurement of the LA ostium, and you see that the maximum diameter here is close to 30 millimeters. So if you want to cover this, we should actually put at least a 25 millimeter device to have at least a 32 millimeter disc. But sometimes we have a big discrepancy between the ostium and the landing zone, and it's not always possible to cover fully the ostium. So looking now at the landing zone, we see that it's relatively small and not so eccentric landing zone. We have a minimum diameter of 15.1 millimeter and maximum of 17.2 millimeter. So the mean diameter is around 16. Looking again at this very nice sizing chart from Dr. Frexa, we see that the minimum is between 14 and 16, the max between 16 and 18. So we have to go for a 20 or a 22 millimeter device. And this is what the simulation tells us, that actually you can go for a 20 millimeter device, which looks relatively good. You can even put it a little bit more distal. You will get some area of malapposition, but relatively the device looks very well into the appendage. But you see that even if you put a larger device, for example, here a 22 millimeter Amulet, either proximal or distal, it's totally possible without over deformation of the device. And in such a case, I really prefer to go for a larger device if you have enough place to put it in the left atrial appendage. So we went here for this size, and I'll show you first the nice concordance between the angio and the CT, because the CT allows you to exactly assess which view you want for the deployment. And first of all, I went a little bit too distal, as you can see here. It's actually a sandwich technique because the lobe is really going into the distal lobe. So I wanted to avoid that, because you see here on the right that the disc is really too much inside the left atrial appendage, and that's very dangerous because you can create a neo appendage, and this is a room of flow, turbulence, and potential thrombus formation. So you should definitely avoid that. But based on the simulation, I knew that I could go a little bit more proximal. So I went more proximal, as you can see here. This is only the second attempt, and this is the final result. I have a very nice compression, good separation, concavity of the disc. So everything is looking very nice. And this is the virtual implant as it was intended. And this is the post-procedure reconstruction. You see that we have, again, a very nice concordance. The post-operative implant is slightly deeper than what was simulated, but you can see that even if we leave here a slight portion of the ridge not covered, this is definitely less than 10 millimeters, so it should not be a big issue for the patient.
Adel,
Yes.
I'm sorry to interrupt you. There is an interesting question coming from the audience.
Yes.
When you mention the case, the orifice is really oval
Yes.
and not circular. That's clear. And the question is oversizing needed to make it round?
You mean for the ostium or for the landing zone?
The
You mean
ostium.
for the landing zone, you mean? Huh?
I honestly, the question is not that precise on that, but I perhaps the
So I will repeat my concept. My concept is that if you have a very eccentric landing zone, for example, if you have let's say 30 millimeter, okay, of maximum diameter and 20 millimeter of minimum diameter, you will see that the on average the mean diameter, sorry, will be around 25, 26, something like that. In such a case, which is very eccentric, I propose to oversize not too much above the maximum diameter. For example, here I would choose a 31 millimeter, but a very important rule that was defined in the article for Dr. Frexa is to never take a device smaller than the maximum diameter for the landing zone, okay? This is very important. And regarding the covering of the ostium, if you, as I shown you in this case, I could go for a bigger device. If you can go for a bigger device, and if Phelps shows you that you can go for it, I will, and if the fact that you take a bigger device allows you to take a bigger disc and to cover the maximum diameter of the ostium, that is the way to go. So it's a very multifactorial approach for the sizing, okay? The most important thing is to place the device nicely anchoring the lobe of the device in the neck of the appendage, but on top of that, you should try to choose a device that will have a disc that will fully cover the ostium. That is very important, okay?
And indeed, the precision is there. Yes, indeed. That in this case, then that the ostium is oval, indeed, but the landing zone will becomes round further down. That's
the landing zone. Yeah, we will become round. Yeah, that's true. Yeah, yeah. I don't know to what extent because this has to be analyzed with CT, but yeah, the appendage tissue will conform to the anatomy, yeah, of course, of the device.
Thank you, Adel.
Okay, I just show you a last case. This is again a very complex anatomy. This is a conic shape, a very elliptical landing zone. You see here on the measurement performed by Trimencio that we have here a maximum diameter of the landing zone of 25 millimeter and minimum of 15. So you see highly eccentric, a mean of 20. And you see here now again what we could try to anticipate in terms of sizing based on this sizing chart. So we have 14 of minimum, we have between 24 to 26. So here it should be at least a 25 or a 28. Looking at the size of the ostium, we have a maximum diameter of 29. So both can be covered with a 25 or a 28, because if you take a 25, the disc of the amulet is 32. If you take a 28, the disc of the amulet is 34. In both cases, we cover the maximum diameter of the ostium. So the question is here, 25 or 28? So looking again at the simulation, we have different simulation for an amulet 25 proximal, an amulet 25 distal. We could go for a 28 proximal or a 28 distal. We see that the 28 distal looks a little bit overcompressed, so maybe it's not important to put a bigger device in that case. I think here the best choice, again, you can decide on yourself, but the best choice here were probably to put an amulet distal to have a nice amount of compression and a full covering of the ostium. So this was the chosen device in this specific case, and I just show you the case which was provided by Philippe Garot from Massy. So the first attempt you see here is a little bit too proximal. So based on what was seen during the simulation, the operator decided to go more distal to concur with the simulation. And you see here a very nice distal implantation and then releasing of the disc. And you see here a very nice occlusion of the appendage using the simulation. And you see here very nice concordance again between what was simulated and what was achieved. And this really influenced the operator to go for this specific implant tension depth. So if I have to summarize, the traditional planning actually is not always standardized. It's highly operator dependent, and it can be challenging to be very accurate because this is what we want to have for difficult anatomies. If you just place a non-compressed simulation into the left atrial appendage, you will lose this interaction between the device and the tissue. When you use the FEOPS heart guide, it's more standardized. Also, you will get all the measurements, which is also good for any operator. This is based on artificial intelligence, and it's clearly scalable. And this prediction of the interaction between the anatomy and the device, I believe it's the future. So if I have to conclude this talk, I would say that computational modeling of the left atrial appendage closure procedure can provide to the doctor a very important insight into patient-specific anatomy and to the interaction between the anatomy and the implanted device. The FEOPS system simulation provides a very accurate implant simulation for the Amulet, but also for many other LA closure device. And the semi-quantitative representation offered by the apposition plots really has the ability to identify or to anticipate malapposition and peri-device leak. And the benefit of this technology against standard of care is actually assessed in a randomized control trial, which is the PREDICT LA trial. So I would like to thank you very much for your attention, and we can go directly for the second quick poll. So when adding simulation in 3D using the FEOPS system, how much do you think that will increase your confidence level in those complex situations? This will not change my decision. This will confirm if my decision is correct. This will impact my decision. Please answer. In the meantime, I don't know if we have any questions from the audience.
Yes, Adel, there is one question.
Yes.
You were highlighting the importance of standardization with the FEOPS technology. And the question is that perhaps this standardization should be applied in trials in order to avoid differences in procedural technique. And what is your opinion about that?
Can you repeat the question again, please?
So that the standardization should be applied in trials, in clinical investigation, in order to avoid differences into procedural techniques.
Of course, I fully agree with this comment. That's why in the PREDICT LA, it's a randomized comparison between CT, standardized CT as we use in our daily practice without simulation, and CT with simulation. And I can tell you that at the beginning of the trial, we wanted to include also 2D TE, but this was not fair because we need to compare apple and apple and not apple and pear. So it's very important that we see what is the added value of FEOPS on top of the standard assessment. And in my opinion, the future will be simulation, maybe, of course, and this has to be proven, but also using CT. CT is very an important tool, and as we do actually for TAVR and for many other structural intervention, it will become the gold standard. It's not the case in the US. It's not the case in many countries because maybe of the availability of CT, maybe because people are not used to it. But I think if you want to have a very accurate procedure, if you want to get the best outcome for your patient, that's the way to go. So everything with left atrial appendage closure is about anticipation and preparation of the case. If the case is prepared nicely, you will have a very straightforward procedure that will not take a lot of time. You will not inject a lot of contrast. So if you prepare your case, case properly, and simulation has a big role in that, I think you will get the best outcome.
Okay, Adel, there is one more question, and then we will also have to conclude afterwards. But the question is, do you use intraoperative TOE measurement or angio measurements to support your sizing? Or are there situations where that still make the sizing change by any of those two?
Okay.
And what is the impact of failing status during the CT?
Okay, I understand. If you have a nice CT, okay, before the procedure, and you know, as I've shown you, you know your measurement very accurately. You have taken your measurement, and you come in the lab knowing which let's say which sizes you are going to place. Okay, it can be two different sizes. You can sometimes hesitate between two sizes, but you have your measurement up front. Okay, you come in the lab and you have other imaging modality. For example, you have a 2D TE, you have the angio, and so on. If the 2D TE tells me that, for example, I have a diameter less than CT, I will trust the CT. So I will trust my best imaging modality for the case. Okay, I use angio not for measurement because this is a 2D modality and it's really not accurate. And also, if you try to calibrate based on catheter or marker pigtail or something like that, it's really you can have big differences according to the calibration. So I use the angio to position my device, to see how to position it into the appendage. But I don't use angio anymore for the sizing. So when I come in the lab, I use CT. But of course, if you use another imaging modality than CT, for example, you don't have CT up front, of course, you have to rely on your TE. You have to ensure that you have adequate feeling of the left atrial cavity. Everything must be clear. And you have to take, maybe if you use 2D imaging, you have to take into account the maximum diameter and not the mean diameter. So that will be my answer.
Okay, superb. Perhaps we can go to the result of the quick poll.
Okay, so it's nice. I have convinced maybe more than half of the audience. So this will impact my decision in 54% of the attendance, and also this will confirm if my decision is correct. So I think people are convinced that a 3D simulation can at least provide very important insights for any operator. So I think it's very interesting.
Super. Thank you so much. Perhaps you can go to the last slide, Adel. Perhaps
yes, of course, yeah.
Can make a transition. Okay. I really want, first of all, to thank you so much, Dr. Aminian. That was a really interesting session. Also, I want to thank the audience because we had a lot of interactivity and a lot of questions. So we are just at the beginning of something new, and we are, of course, extremely glad in FEOPS to participate in that. By saying so, I just want to tell you that, again, FEOPS is very engaged into the education room. That's the education room where you can find on the PCR London Valve main page on the training. You just click there, and there are many other sessions with FEOPS education during London Valve till tomorrow. I also want to thank the organization about that. And last but not least, again, thank you so much, Dr. Aminian, for this really cool presentation. Thank you, and have a good convention. Thanks.
Thank you very much.